This is a recording with a conversation with my friend, Rick Forrest, who is the chaplain at Norton Children's Hospital. And he's coordinator for a program called the Pediatric Bereavement Care. And I want him to talk to us a little bit about what he does. This is usually dropped in one of my courses in a section on death and dying. And largely the students that take this course are students that are entering some form of medicine. They may be a physical therapist, they may be wanting to be nurses or doctors. And so this course is, again, sort of the bigger umbrella of ethics, and then how it applies specifically to medical ethics. And of course, one of the major issues in medicine is the act of dying, which is part of the human condition. So Rick, why don't you just take it over and tell us a little bit about what your job does and about your program. And you really initiated this, I think.
Well, I took over what had been done at the hospital before and expanded it. Our now Vice President of Mission and Outreach, while he was the pediatric ICU chaplain, started a program for supporting families following a traumatic death. And he would go to funeral homes and visit. He would do home visits with families. And then he would do a dinner meeting if the family was willing to, where they would gather family and friends. And he would do some psychoeducation on how we experience and express grief in different ways, how it affects us in our various dimensions of life, in our minds, our bodies, our relationships, our emotions, even our spirits. And then talk about the value of remembering and ways to go about it. And then finally, tips on how to care for each other as a family system in not just the weeks and months that are ahead, but the years that are to come. Sometimes families of a baby, suddenly after about 5 years, have it really kick in again. Well, because that's when their child would have started kindergarten. Mm. And maybe after 14 years, when all their peers are starting high school, they feel that pang. So we're trying to set them up to understand that these things are going to happen. So when he was promoted to director of pastoral care, he decided to expand the program. And I was just finishing up my residency here and was brought in to expand the program. So now what we offer goes to families of all kinds, not just trauma deaths, right, but neonatal deaths in the NICU, deaths of various kinds in our ICU, just a more broad spectrum of things. I am part of a team of chaplains. We have chaplains assigned to our neonatal intensive care, our pediatric intensive care, our oncology service, and our psych service. My role is without a specific unit because I roam throughout the hospital and I'm called whenever a child dies at Norton Children's Hospital. So that begins my walk with the family. The time we spend at the hospital can be extremely valuable because families don't know what to do, and they shouldn't know what to do. It's my job to know what to do, to help them maneuver with a coroner if needed, with autopsy results, with funeral homes and the like. And one of the grants that I have to do my work is specifically to help families with funeral expenses if they're having a hard time getting the funds to pay proper respect for their child. But yeah, I do go out to funeral visitations, sometimes do the funerals, often I bring memory items that our child life therapists have made, whether it's handprints or little fingerprint medallions that the family can wear. And one of the really amazing things are hand or foot molds, where the therapist will take alginate, what a dentist uses to make tooth impressions. They'll mix it up in a cup or a bowl, stick the child's hand in, And then after it's set for a few minutes, they'll bring it out, and in the void that's there, pour in liquid plaster. Once the plaster's had time to dry, they peel the alginate off, and they're left with a sculpture of that child's hand or that child's foot. And families absolutely love that. Another thing we've been doing lately, and if we're able to, is record the child's heartbeat.
Oh, that's interesting.
And save as a digital file onto a little playback unit that is put into a stuffed animal. And the family can squeeze the stuffed animal to activate the playback unit and hear that child's heartbeat coming out of that stuffed bear or stuffed lion or stuffed dog. And have that with them. And I always remind them the batteries are replaceable. Because there's the fear that if I do it too much, I'm going to wear it out. I'm going to run down the battery. What do I do then? So I show them how to access the back of the doll and replace the battery. It's a small thing, but I think a very important thing. So there's a lot of advocacy also. I'm part of the Jefferson County Child Mortality Review, where we monthly meet to discuss autopsies of children that have died, and their death has activated the county coroner's office. There are actually 19 criterion by Commonwealth statute that say when to call the coroner. And so I've been able to cultivate a relationship with the deputy coroners and help advocate for families in those ways. It's not uncommon that I'll help a family get the results of an autopsy done at our hospital and arrange for a meeting with the family, the attending physician who was there at the child's death, the pathologist who conducted the autopsy, and maybe some other subspecialties to help explain the autopsy results to the family. Because I've read a lot of autopsy results, and I often have to have the results in one hand and a dictionary in the other, because they're written for doctors to understand, and families just don't know how to interpret them. So sometimes it's helping families get resources where they live. A family in Paducah is not going to come back to Louisville for a support group, so I help them find resources in their own communities. The travel, our coverage area for the Children's Hospital is all of Kentucky and 32 counties in southern Indiana. That's our primary coverage. Things happen. Families travel through. We get referrals from other hospitals. And so far in the past almost 18 years, I've gone to about a dozen states with families, from South Florida to Louisiana to Green Bay, Wisconsin, Minneapolis, Minnesota, New Jersey, all in support of families whose children have died at Norton Children's Hospital.
Is this program fairly unique to Norton's here in Louisville?
It is. A lot of children's hospitals have bereavement care coordinators. Sometimes they're chaplains, sometimes they're social workers, but they typically tend to stay in the hospital, do support groups, send flyers and mailings out to families, and I do send things out to families. But going out to where they live, going out to their communities is a rather unique initiative.
Yeah, and I have seen you work up close and personal. I pastor a little church in Louisville. Some of my students may not know this, but and in one summer we had 2 children in our church pass away, and we're a tiny church. One was traumatic, one was a drowning, and so that was one sort of approach to grief. And the other family, the girl had been very sick for a long, long time, and
Right.
it was known that her condition was terminal, and sort of helping them realize when the end had come, and to sort of realize that it was okay to stop trying and stop treating. And in both those cases, you reached out to families, had meals with them, and one of them I attended with you. And I just think it's a fantastic, and because I also think more and more families are not connected to local churches. And
Right.
so they may not have, they may not want to reach out to a therapist. And if they're not connected to a local church, they may really be wanting for that resource or some guidance just in what to do next. One of the things that I've talked to my students a little bit about in a lecture, of course, is the classic stages of grief. And we talked about sort of everybody grieves differently and how we have to be careful we don't think of those like Piaget steps where it just automatically goes 1, 2, 3. And you've brought to my attention several different resources and several different approaches to grief as it has moved along. And you actually tell us again this: what is the discipline of studying death, or what it is you do?
I am a fellow in thanatology through the Association for Death Education and Counseling. So yeah, thanatology is the discipline.
So tell us about sort of what is the state of the art in terms of helping people understand grief, approach grief, and whether it's my students who may be experiencing it personally or being by the bedside and trying to be of assistance to families.
Yeah, stages are still out there, but those most closely associated with the field find them less and less useful over time. One of the issues was Kubler-Ross's original research was on those who were told they themselves were dying and tended to exhibit these characteristics. And that makes a lot of sense. When you try to apply it to those who are grieving, it doesn't work so well. My grandmother died in her mid-80s after a long and fruitful life. So if I wasn't mad, was I not doing it right? You see, people get caught up in, you've got to go through these stages in this sequence. When the way it really plays out, you go back and forth.
Mm.
And you don't do it in sequence necessarily. Well, in the 80s, we started looking at things a little bit differently. William Worden out of Harvard came up with tasks, things that we accomplish as we grieve. And one of the strengths of tasks is you have a sense of agency.
Mm.
You are involved in processing your loss. You're not just finding yourself in a stage, you're actually doing something about it. Others have come up with similar task theories. Then, out of Holland, came this dual process model where they say when we're grieving, we engage in two different kinds of behaviors: grieving behavior and what they call restorative behavior, taking care of business. And in the visual for their model, you have these two ovals for these types of behaviors, and then a zigzag that runs between them. That's the oscillation they talk about, in that we will grieve for a while, and we'll take a break for a while and attend to the needs of life. But we re-enter the grief and go back and forth between these two poles, as it were, as a way of processing what we need to. The problems I see sometimes in a family is when someone says, well, they grieve all the time and don't take a break now and then, and they wear themselves out. But the more common thing I see is when someone says, I'll deal with that later, and they get busy doing and doing and doing and doing. And you got to stop sometime. And when they do, it's right there waiting for them undiminished.
Mm.
So it's in this process of moving back and forth, according to Strobe and Schutt in Holland, that we tend to process. Some other theorists look at types of grievers. Ken Doka and Terry Martin looked at the way people grieve, and you know how the old adage is, men grieve one way, women grieve another. Well, what if you got a man who grieves in a more traditionally feminine style?
Mm.
You don't go up to him and say, buddy, you're grieving like a woman. He's going to smack you one real good. On the other hand, I also see women who grieve in a more traditionally masculine style. They get their armor up. You're not going to see what's going on with me. Well, Doka and Martin looked at this and said, there's something going on here, but we've got to get rid of the terms masculine and feminine grief. There's just too much baggage attached.
Yeah.
So they came up with the term intuitive grievers and instrumental grievers, types of grievers. Now, none of us are completely one or the other. We're all somewhere on the spectrum. But intuitive grievers are the ones we typically think about as grieving. What's going on the inside shows on the outside. It's very expressive, very heart-driven. Want to talk about things. You see the crying and such. Instrumental grievers we often overlook, and we assume they're not grieving. They just are in a different way. With an instrumental griever, what's going on the inside doesn't show on the outside. They may not want to talk about it. It's very head-oriented rather than heart-oriented. And so they want to do things with their grief. In their book on the subject, Doka and Martin talk about a dad whose teenage daughter was killed in an auto accident around the corner from his house. She was coming home late one night alone in the car. The roads were slick. She lost control, crashed through a neighbor's picket fence, and hit a tree and died. The day of the funeral, Dad picked up his toolbox, walked to the neighbor's house, and began to rebuild the fence. Well, you can imagine the neighbor came out and said, man, you don't have to do this. It's all taken care of. The insurance company's got somebody coming out next week. You really don't have to do this. But the dad said, yeah, I do. I couldn't fix what happened to her, but I can fix this. It was a way for him to process with his hands what was going on inside his heart. So now we're looking at some of those things. But there's also a lot of work being done these days in two other areas that are pretty significant. One is the effect of, how do I put it? Attachment. Back after World War II, John Bowlby started studying attachment theory and how children attached to parents, looking at nature around us with geese and swans and primates, seeing that in human children too. The attachments that are formed early in life have a reverberation throughout our lives and how we attach to other people. Now they're looking at how that works its way out in grief. The attachment style of an individual affecting how they're going to react to a loss. Also, another area is coming from constructivist psychotherapy, in that we make meaning of our experience in life. And what meaning are we making of this particular loss? Now, I use the word loss purposefully, because what I'm teaching our students here at the hospital, early on in their training, I talk to them about losses that they're going to see. And I ask them to do a timeline on their earliest memory of loss up to now. Well, oftentimes they will talk about, my grandparents died these ages, my aunt or uncle died, a parent died, my dog died. Sometimes they'll mention a non-death loss, and that's very important. My divorce. I lost a dream. There are very important losses they're going to encounter in the hospital. Loss of an assumptive world, of how things are supposed to be. Mm-hmm. And when I get that diagnosis that came in out of the blue, I'm not supposed to get cancer. All the men in my family die of heart disease. That's a loss. Relationships can be losses. So I try to attune them to the various modes of loss that they might encounter that aren't death related. That's just trying to set them up for some of the stories that they're going to hear when they're ministering in the hospital.
Yeah, that's so interesting, and I appreciate that. I'm going to run down some of those as well, but I think it will help students to sort of try to position themselves as they are standing by people that are hurting and grieving. I know from past years when we've had this conversation in class in person, you've shared with us some pretty dicey ethical situations that you have been privy to because you were called into the situation. Could you share just one or two with
Sure.
us in terms of some of the ethics that sort of come in this hospital environment?
So one of the cases that we frequently talk about was several summers ago. We had an infant brought to our emergency room that something was wrong, and we knew something was wrong, but we weren't quite sure what. The parents had been to several immediate care centers, and when some uncomfortable questions were asked, they left and went to another one and another one. And finally, the child's condition was such that they needed to go to the hospital. And they did. And one of the things we look for when children are brought in like that is what we call petechial hemorrhaging. Hemorrhaging in the retina of the eye, which suggests shaken baby. Mm. And we found that. And the child progressed to brain death, which meant legally the child was dead. There are certain tests that we do at the bedside, and there are certain tests we can do with nuclear medicine to legally determine brain death. Dad took off and was arrested and held on suspicion of child abuse. Mom, who didn't speak English and had only been in the country a month or two from Mexico, had her spiritual guide with her, her pastor with her, and they were of a Pentecostal tradition. And so they were holding out for a complete healing for this child and refused to allow the staff to disconnect any of the ventilators or drips that were keeping the body functioning. I use those words very carefully. I didn't say keeping the child alive. The child was dead. Brain function had ceased. And the only thing keeping that child's heart going and breathing was the medication that were and the ventilator to keep things going. So we have this dead child. Family will not allow anything to stop. They even brought a lawyer in to prohibit medical staff from discontinuing treatment. This went on for weeks and weeks. Mm. And it brought some ethical issues into play, but some other things as well. Of course, now we're talking about what we in the hospital will sometimes call, maybe I have COVID head, I don't know, but basically non-effective treatment.
Right.
The treatment was not going to have any positive effect. Futile treatment.
Futile treatment. Yeah, we read that article about futile treatment. Yeah.
Futile treatment. Nothing the doctors were going to do was going to reverse what had happened. Now we're talking about using a lot of resources that could be used in other situations with effect, but they're all being poured into this futile situation. So justice is involved with this. Questions of non-malfeasance come into play. Nurses were becoming concerned that they were going to be brought up on charges of desecration of a corpse. because this was causing moral injury to the staff. And so while we tried to minister to the family, we also had to do a lot of work with the staff because of the things they were being pushed to do because of the legal system. This went on for quite some time. And the lawyer tried to say it's the parents' decision on what to do. And that comes into autonomy. A child doesn't have autonomy, but the parents make decisions. Well, really that kind of ends at death. And the decisions they make are that of a funeral home and what to do, whether to do cremation or burial, those kinds of things. The medical issues are out the window. And yet the lawyer was arguing that the jurisdiction was wrong. It should have gone to a different form of court and all this kind of stuff. Finally, the lawyer lost. And the judge ruled that Norton Healthcare was within their rights to discontinue ventilator support and the medication that was keeping the baby's heart going. And that's what we did. We gave the baby into mom's arms as we discontinued things so she could hold the baby while the baby's heart stopped. It was hard for everyone. We had tried to understand the religious objection the family had. So we arranged a meeting between the attending physician, a translator, me, because of religious understanding, the mom, her pastor, and right before the meeting was to be held, simply to understand their perspective, the lawyer swept in and canceled everything. So there'd be no discussion of religion, faith, anything like that in relationship to this child. Well, that made it hard for us to understand their perspective and what would be helpful to them in this time.
Yeah. I remember also in this case, you've got a conflict of interest because the father who stood accused of child abuse would then be on suspicion of murder.
Exactly.
If the child was declared dead. And
the charges would have gone up, yes.
And then the longer the child, the body remained on all these systems, then any sort of forensics or any sort of evidence that would have existed is now essentially compromised because of the length of whatever.
Yeah. Basically, the child's brain liquefied. And so no autopsy on that part of his body would have shown anything. And therefore, evidence was lost in that kind of a case. Yeah. Another case was with a baby who had a heart defect. And parents kept delaying decisions over time. And so he began to die from the outside in that his hands and feet changed color. And that coloration began to progress down his arms and up his legs until his whole body was a different color. And it caused pain to the child. It caused distress to the nursing staff. And we finally had to call in a next consult to try to understand the family. They just didn't know what was going on. They just didn't understand what was going on. But finally, they decided to withdraw ventilator support and allow the child to die naturally. Language is important. I didn't say withdraw care, because we still cared for the child. We still cared for the family in all of this. But we withdrew the medical interventions. One of the issues that the doctors and the nurses struggle with is the question, are we doing this for the child, or are we doing this to the child? Once again, that non-malfeasance, that sense of beneficence, all come into play. And sometimes these ethical bedrocks conflict with each other. And you have to weigh one against the other and try to come up with a solution that works for as many as possible. One of the issues with non-malfeasance is this double effect doctrine, in that at end of life, we want to make the patient as comfortable as possible to reduce suffering as they die. But the medications that are used to alleviate suffering may also hasten death. And so we have to struggle with those kinds of questions at a time like this.
Yeah, good. Thank you. Those are things we'll be pondering with for a while.
Oh, yeah.
Tell me about what usually when you come into a class in person and when you wrap up, I always ask students if they have questions. And one of the questions that almost always comes up is, how do you do this? How do you go into work every single day knowing that the only people you'll be called upon to minister to have just lost a child? And that's got to take a toll on you personally. And again, most of the students that will be watching this are heading for healthcare careers. And, all healthcare providers get at the point where they've just seen too much hurt. They've been through a rough week where they've stood by and watched people suffer. How do you deal with it? And then what tools, and I know you've studied resiliency, and talk to us a little bit about what that means.
Okay. Yeah, there are still visions in my head that I can recall that stick with me over time. Last summer, we had a toddler whose face was chewed off by a dog. I can still see him. It doesn't come unbidden, but the vision is still there. I try to see every child that dies. If I'm able to be called in, come in, I want to see them, because I want to see what the staff is seeing to better understand them and what's going on with them. When I was doing my clinical training a long time ago, I had to figure out what were my clues that I was getting a bit too close to the edge. The big one for me was I'm losing my sense of humor. I can't laugh. Things have just gotten too serious. That's a cue for me that I need to take a break, to do something about what I'm seeing and intervene. So I found that there are a number of dimensions that I work with. There's the emotional toll that goes on with this. How do I process that? Sometimes it's meditation, prayer, getting away. Physical toll. I get called at 3 a.m. I'm not getting any younger. And those 3 a.m. calls are getting harder and harder. So I have to be careful about what I eat, about the sleep that I get, the exercise that I get. There's sort of a rational part to it. I have to keep perspective. I had a colleague that worked in the ICU a few years ago who, when that colleague left us abruptly, they wrote a letter to the staff that said, "I didn't realize that being a chaplain was all about death." Even I know that that's not true. That colleague had lost the perspective and didn't seem to see that more children leave our hospital alive, well, and happy than leave dead. Now, if anyone should have that perspective, I know I should, because that's what I see all the time. But I know a lot of good things happen here. A lot of happy things happen here. And so that helps me to keep things in perspective. This is not all that happens at our children's hospital, even though I'm the one who sees it most. There's a theological term called Theodicy. How does God get away with it? Basically. There's evil in this world. How do you reconcile that? And so I had to spend a lot of time working out a theodicy that worked for me. And it's always in revision. Because the questions come. Why'd this happen? Why do these things occur? Why do children die? And a lot of the pat answers don't work for me anymore. There are a group of words, 4 words that I dread hearing when I'm with a family at the hospital. Because what will happen is someone will say something to the parents. They're trying to be helpful. They're not. Things like, they're in a better place. When for the mom, the better place is in her arms right now. At least you have other children. Or at least you can have other children. And I've heard from families that they've gotten these statements. God needed another rose in his garden. God needed him more than you do. Can you imagine hearing some of those things told to you when your child is right here and has died? So the words that I dread. I'll be with a family and maybe an aunt or an uncle, maybe a grandparent, maybe even their pastor will come in, say to them one of those things. They're in a better place. God needed them more than you did. Then they'll look at me and say those 4 words. Ain't that right, chaplain? Now, they're wanting me to agree with them, to validate what they're saying. In our training as chaplains in clinical pastoral education, they train you to be a, quote, non-anxious presence. That doesn't mean you're not all worked up inside. So they'll say those things and then give me the 4 words. Ain't that right, chaplain? Deep inside, I'm going, what are you, nuts? But being a non-anxious presence, I can't say that. And so I'll may say something like, well, some people find that comforting. I'm not buying into it, and I'm not going to validate it. It's a way of pushing a meaning onto that family's experience for them. And I just can't do that. We hear a lot of things and see a lot of things in the emergency room and all over the hospital. And we have to find our way of knowing the clues, if it's too much, and then how to care for each other. And so I'm now part of an initiative at Norton Healthcare to provide interventions for staff when terrible things happen. I've done study in critical incident stress management and psychological first aid, and we're going to be deploying groups to help with those situations with what we call critical incidents in the hospital to help support staff in coping with the experiences that they face.
Oh, that's fantastic. So if a student who's watching this, who's in one of my courses in ethics or medical ethics, and they find this stuff sort of interesting and they think, gosh, being a chaplain or being involved in this way in medicine might be really interesting. What would they do? What would the next thing they should look at?
To be a chaplain, you need a seminary degree, and then you typically need to go through what's called clinical pastoral education, which usually means a 10 to 16 week intern unit, and then a year of residency. And they're available at Norton Healthcare, in which you would have experiences at Norton Women's and Children's, at Norton Children's, at Audubon, at Brownsboro. Baptist also has a program. University of Louisville has a program. And then there's what's called a parish-based program for non-hospital placement, that's run through the Counseling Center at St. Matthew's Baptist Church. But it's a very intense program in which you get clinical experience and then the analysis of that experience. So it's a lot of personal work going on there. It's sort of a pastoral care boot camp.
Yeah, it sounds like it. Well, that is so interesting. Well, is there anything else you want to leave us with? Anything else we need to? I think we've covered the usual ground.
Well, if folks have questions, you know where to find me.
Okay, fantastic. And how has this pandemic affected the staff as they try to provide the same standard of care with a very different reality? What are you seeing?
A lot of stress, a lot of anxiety, because they have to be so careful about what rooms they go in and how they go in those rooms. Another part of it is we have to restrict visitation.
Yeah.
Even at end of life, there are restrictions on how many people can be in the room and what happens once they leave that room. Once you leave the room, you have to leave the building. And you could only have maybe 2 people at the most in at a time. It causes a lot of strain for the staff who are caring for the patients and caring for their families as well. And sometimes we've had to do things on Zoom to help families see their patients. I've just learned of 2 friends of mine in various states who have been hospitalized with this just recently, one of whom is still in the hospital. And it's affecting how their families get to interact with them. And not just COVID patients. It applies throughout the hospital. I've got a nephew in Florida who just had a kidney transplant, and his family could only see him 2 hours at a time, a day. And for the first several days could not see him. He doesn't have COVID, but he's still in the hospital.
Right.
So it affects not just COVID patients, but all patients in the hospital.
Yeah. All righty. Well, thank you very much for your time. And I think
Sure.
kids are going to definitely benefit from this. And we'll keep you in our prayers and keep up the good work.
Thanks.
All right. Thank you, Rick.